Hello class, in this video we will be talking with Patrick Chen, who uses data to improve health. Hi Patrick.
Hi everyone, my name is Patrick Chen. I work as a manager of population health intelligence at Martin Luther King Jr. Community Hospital that's based in South Los Angeles. And my current role is to essentially innovate solutions through data analytics to make sure that we are doing the best that we can to develop programs that can optimize population health and make sure that both our inpatient setting, outpatient setting, and community health are doing as well as they can be.
Awesome. Do you mind sharing a little bit briefly of your training and any identities that you may have?
Sure. Identities, probably the most relevant one. I'm a first generation student for my family. My parents are immigrants from Taiwan, and I empathize with a lot of the struggles that first generation students have, especially in California. Mm-hmm. My training, it started off really in public health. My undergraduate degree is in public health policy, and that really shaped the way on how I think, making sure that when I'm designing solutions, they make sense. They impact both community health, inpatient settings, outpatient settings, and making sure we have that holistic image in mind of what health is for a person. And so with that training, I then transitioned into an analytics role. I did research at UC Irvine for an epidemiology professor. My background in general is related to biostats and epidemiology. And so as I worked as an analyst, I started to work on projects that were data-driven. And that's where I started getting a lot more exposure beyond the initial research databases of how to drive analytics in a hospital setting. Then I transitioned to work as a performance improvement engineer. There I became more of a project manager in figuring out how to implement certain projects. So a lot of times research, it gives you all the information you need, but then you need to take that information and then figure out how best to impact the population with the information that you have, and what you've learned from them really. Then I transitioned to work in a role where I started developing predictive models for anticipating health outcomes. And this is where it was really important, especially as we all understand for public health setting, preventative health is the most cost effective. So instead of waiting for a heart attack to happen, we'd predict when a heart attack would happen, and then we send out resources, send out screenings, making sure they stayed in touch with their cardiologist, the primary care physician. And it was something that could be both population health conscious and also financially relevant as well. In my current role, it's kind of a blend of everything I've done so far, honestly. I work very closely with health IT to implement technological savvy solutions, making sure that we have the right amount of technology in place so that we can enable features like telemedicine, mobile clinics, etc. I work closely with clinicians. I actually report to a physician, and we work on developing and understanding what is the most at-risk population that we should be addressing immediately. For example, the mental health population, it's right at the forefront of a lot of the public health discussions. And so we are actively categorizing, risk stratifying populations so that we know what type of health programs would be the most appropriate for them, and making sure that they're affordable as well.
Wow, that's awesome. It's a lot of analytical skills, but in the context of health services and addressing what the community really needs, right?
Exactly. You partner closely with a lot of different organizations because you can't do it by yourself.
Awesome. Yeah. Perfect. So can you share, I mean, you did share what you do. Can you share a little bit about why you are doing this?
Why am I doing this? There are a lot of reasons. Initially, when I first went into public health, I was fascinated by the idea of allocation of resources. And this is what really jump-started my thought process on how can we create solutions that make sense on every aspect. And by every aspect, I refer to things like, well, what's best for a patient, what's manageable for a business, and what makes sense for a community by itself. And so this allocation of resources, ultimately, I think personally, I feel like it's at the heart of every health-related problem. If you want optimal health, you can make $50 million a year, have a personal team of physicians. Seriously, cardiologists, endocrinologists, audiologists. You have all of them, right next to you, checking in with you every day, and that is probably the best possible health outcome you can get. Problem is we don't all make $50 million a year. And so the idea behind it is, well, how do we scale that back? And how can we optimize health for a population or for an individual based off of the resources that we have available? And all of that was from I had family situations where they got really sick, money was tight, insurance didn't cover everything. We had to travel overseas for certain treatments, and it was such an odd situation that started to get me just fascinated with public health in general.
That makes sense what you shared, being the child of immigrants, like your parent, or I don't know who it was, but the family member having to, because we don't have universal health care here, go elsewhere to find affordable treatment.
Yeah, because this is pre-ACA, keep in mind. So it was just, and plus they didn't understand the system. So theoretically, I suppose we could have navigated it somehow, but it's odd that someone who lived here 20 years is more comfortable flying back to Taiwan for treatment than staying here. And from that allocation of resource, personal crusade of sorts, then I started realizing, okay, so what do I need to determine which resources need to go where? And that's where analytics came into play, because you cannot manage large populations without having a robust analytics process in place. And that got me into the coding part of it, relational databases, SQL programming, understanding statistical models, that would be able to enable that end goal of being able to allocate resources as best as possible. Because it's difficult when you sit there and you have a budget of X amount of dollars and you have a few million people that you need to manage. Like, what are you supposed to do? And I feel like that's what happens to a lot of public health professionals. And so we just do things one step at a time, and we figure out how to address one population at a time.
Yeah, that's awesome. That's so exciting. I'm like extra excited because in my prior life, I was a computer information systems major, and so like hearing about all the data stuff is exciting. So I think you already described your career path thus far. Are there any other jobs or any detours that you encountered along this pipeline or along your pathway?
Not really, to be honest. It's been more of cramming two roads into one for the most part for myself. I'm a firm believer that, efficiency, as I worked through allocation of resources, efficiency became kind of my thing. I got certified in Lean Six Sigma when I was working as a process improvement engineer for a hospital, and figuring out what things made the most amount of sense worked out well for me. But quite honestly, a lot of my peers, they've done a variety of things, and public health is still what they're passionate about. So any path is possible. Healthcare really uses just about every possible career, from business to IT to community health workers. You see everything really in a hospital.
Cool. All right. So we kind of talked about this briefly before we started this, but what area of public health do you kind of see yourself in? Yeah.
That's an interesting one, but really I'd say it falls between biostats and epidemiology, and then broadly in terms of a professional title, it falls under population health analytics. And so in a normal academic public health setting, epidemiology and biostats are technically different, but really everything gets blended together when you work in industry. You wear a lot of different hats.
Cool, thank you. I know sometimes explaining to students what the differences between biostats and epi, it's kind of more about like, okay, well, what are the tasks that they're doing, but then in a role like you have, they're kind of doing all of that.
It's very important to just keep everything broad and learn as much as you can about everything, especially if you're early on in your career, because you can branch off into just about anything if you start off as a public health professional. I've seen people with the exact same major as me work as nurses, work as doctors, they work in fields like myself, they work as community health workers, they end up going into hospital management, medical group management. You can do just about anything.
So for some of our students who are less familiar with public health, because in this class there are folks who are maybe in more hard sciences, some folks who are in business. I think we might also have some criminal justice folks. Can you briefly explain what biostats is and what epi is, just like very briefly?
Right. So epidemiology really is about studying, in our case, how disease distributions happen across our population. And so we focus heavily on figuring out what is causing these conditions. And ultimately that really comes down to, well, how can we fix it? We like to think of it as we like going upstream. go to the root cause.
Mm-hmm.
A good example, we have cases where we have diabetes patients who aren't taking their insulin. And then you're thinking, why is this patient not listening? Is it, well, we can't just blame them technically, but like if they're not taking their insulin, if they're not taking their medication, what are we supposed to do? And then we find out later on that they are living in their car. They don't have a fridge. They don't have electricity. What are they supposed to do? It's really not their fault. And so what do? We go buy them a cooler. We'll go pay for electricity bills. We'll do what we need to. And it makes sense from just about every perspective. You get them the medicine, you give them a place to store it, and we save them from having to come into the ED with hyperglycemia. It just makes sense. But that type of knowledge won't occur unless you are willing to dive deep and not blame the population for what's happening to them. Yeah.
Yes. Awesome perspective. Can you briefly describe biostats?
Yeah. And I'm sure there's a formal definition for it out there, but personally, I find biostats to be much like the formal role of a statistician, where you dive for statistical correlations. You find out what is causing potentially genetic disorders. And that's really where I stand for biostats. It's about the formal correlations, the mathematical correlations, and epidemiology is about diving to see where the disease distributions are happening and why they're happening.
Awesome, thank you. So what do you think is the best part of your occupation, what you've been doing for the past few years?
Yeah, that's a great question because I enjoy my job very much. It blends two things I think that I'm mildly obsessed with. And I'll use this term mildly. I'm obsessed, as I mentioned, with allocation of resources, and I'm obsessed with analytics. And so when those two get tied together, it's about really figuring out how good can you be at this role. How can you make this program be at its best, make the most sense, and expand it? Because as I've mentioned, sending a physician team home with every person is probably the best chance of optimizing, their health outcomes, send them home with, a social network. Can you imagine if everyone just had their own social network, people they could rely on, parents that are always there, they would do so much better in every aspect of their health. And so with that part of it, with my obsession with allocation of resources and making sure things make sense, then there's also the part of making things happen. So I can sit in a little room and generate and giggle to myself about, oh, look how amazing I made this model. This makes so much sense. But if I don't figure out a way to implement it practically, then it's useless. Information without project management implementation, like, well, nothing's going to happen. Project management without proper analytics, like, well, you don't know what's going to happen. You just set something up and you hope that people will come. It's kind of like when they say you build a hospital and people will come. Where our mindset here at MLK Hospital is that we want to inject resources into the community. And oddly enough, we want it so that people don't have to show up to our hospital. Our leadership team is on board with that. It's not something you see very often for a hospital. We actually actively say, we're trying to keep people who don't need to be in a hospital outside of the hospital because we don't want that to disrupt their lives. Come to a hospital visit, it's impactful. It's one of the most difficult days of their lives. So.
Yeah, that's a great thing that you pointed out, because a lot of times when people do think about hospitals, they think about how profitable it is for, patient beds to be filled and whatnot. But it sounds like at MLK, and then, maybe it is kind of more the history of that hospital. They are more concerned with the health of the population rather than, again, like filling their beds and making the most money from their patients, right?
Exactly. Yeah. And so with all of that, analytics, all this leadership support, it lets us push through for initiatives like developing telemedicine for people in the community that need it. So that people who can't even come to our hospital still badly need services, but maybe don't need to call an ambulance. This way they can phone in and call so that they can get a consult if they have an iPad. These are all things that we're evaluating, and hopefully we can implement. The leadership is on board with it, and so all we need to do now is figure out how to do it. So
that's exciting.
That's where it comes back to population health analytics.
Cool. So what, on the flip side, would be the most challenging part?
And the most challenging part really has to do with making it all come together, because it sounds like it's a step-by-step process, but in actuality, you end up having to flip back and you run in circles sometimes and you're not sure what's the right answer. And if you don't implement it in the right way, then you'll impact their health outcomes. outcomes really. You know, if I implement a predictive model for catching heart failure, and let's just say, you know, you capture 90% of them, oh great, that's actually pretty good for, especially for
great.
AI models, like that's pretty good.
Yeah.
What about the other 10%? What about the false negatives that you got? What happens to them? And so the most difficult part really is knowing when, you know, the most difficult part really for me is figuring out how do I capture all those little nuances in a person's life and make sure that we keep that in consideration when we're developing programs. So, you know, if we implement something like telemedicine, it's like, well, do we have to make sure that they can at least afford a small copay, or do we just waive the copay whatsoever? And trust me, building a business model where you waive all of health service fees, it is not something that's easy to work with, seeing as we're not a public health agency. Yet leadership is still excited about it. They still want to push through, and so we'll just have to work out how we build a business model where, and in this case, really, I wouldn't call it a business model anymore. It's really just a model for community health. How do we go out and impact the 1.3 million members in our area that we serve? How can we just make their lives better? And some of it comes down to we're developing a food prescription program where our physicians can prescribe healthy food. We tie that with classes for them. We take them to grocery store tours so they know what they're looking at. You know, some of them might not have even purchased a cabbage in their life. It's possible. It's the area that we serve. It's extremely medically underserved. There are very few physicians in the area. I'm not sure how many members in this audience really understand insurance payers, but we have the most disproportionately Medi-Cal payer mix in pretty much LA County.
We covered health insurance earlier on in the semester, so hopefully they remember what that is. But yeah, and I think like sometimes it is a different challenge, right, to be thinking about people from the data perspective, right, and forget that there are humans attached to the other side, right, and so bringing in that human perspective of, you know, how is this actually going to impact them on a day-to-day basis, and getting to know them. And yeah, I think my question is, do you collect qualitative feedback from the patients that you're seeing, or the people that are being supported by these programs?
Yes, absolutely. I pretty much all my projects, I will include some part of that component that I know I can't quantify technically, and conduct interviews and discuss them with them. And I refer them as like community engagement sessions. So for example, if we want to design a health intervention for them or a program for them, and let's just say that program revolves having a mobile clinic. We can design the clinic as much as we want, but if we don't make sure that the community is on board with it, they like how it looks. I mean, it's accessible, and sometimes it just boils down to, do they like the name of it? Like, all these little things that we take into consideration, because that human aspect can't be ignored. And that's something that I always keep in mind, especially since I run numbers so often. You know, I've worked in roles where I've had to analyze hundreds of millions of data elements, and making sure that, well, even after I push through what makes sense on a statistical level, that I have the clinicians jump in. You know, we talk through everything. And I discuss a lot of the thing that I'm working on these. You know, I don't work on this alone. I work with clinicians on it. I work with IT on it. I work with frontline staff. Pretty much every project that we're developing a health program for, we engage nurses, physicians, OT/PT, audiologists, everything. Anything that's relevant to their field, we will make sure that we talk to them about.
That's cool. Awesome. So kind of relevant to your last point about making sure that it aligns with what the patients are interested in and what they would support. Have you seen culture and language influence the services that are in your field?
Yeah, definitely. Some good examples. Well, we have a pretty heavy Spanish-speaking population, and then on the west end of our service area, you have a lot of African Americans. And so tailoring services to make sure that we meet their needs is a huge part of what we have to consider, because what will work for the Hispanic population might not work for the African American population. It might not work for the Beverly Hills population. Like, you have to take that into consideration and make sure that you make regional adjustments, which isn't the easiest to do as a hospital. It's not like we're a broad health system where we're covering different states. And so they'll just tailor maybe by state, maybe by city. But we have to be mindful of the fact that we have housing projects just north of us. We're like half a mile away from where all the Watts riots occurs, a few decades back. And so making sure that we understand the context, and that's why we have our community coalitions. We have a community benefits coordinator that is well-versed in how the organizations around us are interacting, what they're expecting. Because no matter what, when you open up a brand new hospital in a region, you've changed the ecosystem for the better. I really believe so. Hopefully. But you've changed the ecosystem, and you need to make sure that you stay in touch with your community leaders, because they're the ones that are living there day in, day out, and we need to make sure that we align our purpose with theirs.
That's huge. Yeah. On that note, can you briefly share with the students, when did MLK Hospital open?
Right, MLK Hospital, right? MLK Hospital opened in May of 2015.
That was 3 years ago.
That was 3 years ago. And so with the opening of a hospital, which is a very rare thing, really, especially in California, with all the hospitals closing for seismic regulations and new laws, the key part of that has kind of defined our hospital is how willing we are to go out to the community and look for those root causes and solve the problems where they're occurring. Part of that is that we see our hospital, and the estimations when they built the hospital were to see about 45,000 ED visits a year, which is a pretty large amount for a hospital that is only 131 inpatient beds. For context, if you guys have heard of the USC hospital, I think they have they have hundreds and hundreds of beds. So they're like 4 or 5 times the size of us. We're built for 45,000. We are on track to see 120,000 ED visits potentially at its most, but we are definitely going to see over 100,000 ED visits. It all depends on flu season coming up. So seeing well more than double what you were built for is a very difficult situation to be in, but it also kind of defines what the hospital is working towards. Prior to us, there weren't very many hospitals in the region. And so when the old MLK hospital shut down, when it was a different organization completely, back in 2007, they went 8 years without a hospital in their region. And so now that we've reopened, we're seeing these types of volumes that really, they're just this indication that these people needed healthcare for the longest time and they just weren't getting it.
Yeah, that's a great point to make. Just because the hospital isn't there doesn't mean that the community doesn't need it.
Exactly.
Right.
Yeah.
Yeah. I think, if I recall correctly, some of the students mentioned in one of their first activities, like their long-term goals and whatnot. And I know folks were interested in like opening clinics and in medically underserved areas. So lines of that.
Yeah, that's a great point. Yeah, we realized that as a hospital by itself, we weren't able to do everything. And so we founded a medical group. It started December of 2016. I work on a fair number of projects with them as well, because it's a big part of population health. And basically, we're just planning on opening up clinics and just filling that physician deficit, because based off of the estimates from this group, they estimated that the South LA region had a 1,200 physician deficit. Wow. Where are people supposed to go? They don't have the clinics next to them. Sometimes they need a cardiology appointment and tells them it's 3 to 4 month wait. You're probably going to end up in a hospital before that 3 to 4 months ends. So,
that's frustrating.
And so we take the brunt of it afterwards, because then the patient show up in our hospital.
Yeah. So if this sounds interesting to you as students, of being able to use this data to address these very real issues that we've been talking about this semester, what should an undergrad do? Like, what advice would you give to someone who is currently still in the undergrad phase if they wanted to pursue a career like yours? Not exactly the same pathway, because we realize that everyone has different paths, but what are some things that they could take into consideration?
Right. And it's really valuable to have different paths. For example, I'm hiring people for our team, but it's unlikely that I hire someone with the exact same background as myself. Like, why would I do that? Like, I'm not expanding our knowledge. It doesn't make any sense. In fact, I'm specifically looking for people with different backgrounds than myself, because I need that extra perspective. I need people to supplement what it is that I already know. And so my general recommendation, before I dive into maybe specifics, is if someone has a goal of a specific role, for example, you want to be the administrator at a clinic, you want to be able to open up new hospitals, or probably a little rarer. But open up new healthcare facilities, maybe. Find people on LinkedIn where you see that they have that role. Look at their track record and figure out how they got there in the first place. And then you can reach out to them, call them, talk to them. That's what I did actually. I called people that they were like chief operating officers of Kaiser, and they would still reply to my messages, pick up the phone when I was an undergrad student, and talk to me for a good 30 minutes. You know? Wow. And that, normally as a consulting fee, that'd be a few $100s. Like,
wow.
So that's my general recommendation for anyone that's pursuing a career shortly after undergrad. And as for work in population health, you really can work in it from a variety of fields, from a variety of backgrounds. If you're looking for a more data analytics driven role, I highly recommend you get involved with research, quantitative research, ideally in the epidemiology or biostats department, to just get some exposure on how people quantify health. That's a big one, because a lot of times I'll get the question, okay, Patrick, we want to do something about our amputee population or our psychiatric population or our suicidal/homicidal population. How do we define those, and how do we develop key measures related to them? And that's all tied to research. And so this is where I think getting some involvement with professors, they've been doing these for decades. They will have a lot of information to share with you. And then specifically dive a little bit more into software. Generally, every role in any company, you're required to use software at some extent. My recommendation, if you want to work in analytics, definitely be familiar with data extraction software. That's generally data warehousing. Honestly, if you just learn SQL, you're probably good. If you need to choose a specific dialect or version of SQL, I would choose MySQL for Oracle or SQL Server, which is Transact SQL for Microsoft's version. Those are the two most prominent ones. After that, I primarily use those as data extraction or logic building tools. After that, you should get some exposure to statistical packages. This is where your professors are really, really helpful, because they likely use this because it's kind of hard to do research if you're not quantifying things with stats. And so they're probably using some version of Stata, R, or maybe even Excel. My recommendation would be R or SAS, which is I believe it's statistical analysis software. SPSS is kind of out there too, but not too many people use it in industry. So I would recommend between R and SAS. And Excel is kind of the requirement for just about any role. It's kind of, you have to know it. So I would recommend learning how to do a specific function there, writing some basic code, some queries, VLOOKUPs, index matches, things like that.
Awesome.
Yeah, and so after that, with research, honestly, you're pretty well equipped to do an analyst role. And most people like myself that are hiring analysts, we value that research position pretty well.
Is that something that someone could get straight from undergrad?
Research positions? Yeah. I did undergraduate research. And so I think it was 4 units. I think it required 12 hours a week. It was in a UC system, so it's like it's East Coast. It should be something similar to other people who are studying here. And then my recommendation is get some exposure to government, public health agencies. So try and intern for things like the Orange County Healthcare Agency, LA County Healthcare Agency. They have hundreds of roles, I believe. I mean, they're huge. If you can't get a hold of that, there's still other nonprofits that you can join. And they're honestly, most people are looking for interns. And so those are your best 2 options. But technically, you can also intern for a direct healthcare organization. They're usually a little bit more involved. Might require 15 to 20 hours a week. But if ever the reason for you to not do something is because you're too tired, you're too lazy to do it, just do it. Just go for it. You'd be surprised at how much you can accomplish in a 70-hour week. Sometimes it's school time. It's good.
Yeah. Awesome. So definitely a lot of great tips. And thank you for mentioning specific software that students can use. Know that as students, you also have access to Lynda, Lynda, through Cal State Fullerton, and you can learn some of these statistical packages, as well as how to strengthen your Excel skills for free without a graded class through Lynda.
Yeah. And just to jump in,
yes.
I think I've seen every one of those softwares on Lynda. So
yeah,
it's fantastic. Yeah.
Great free resource.
Yeah.
No grade, but if it makes you competitive for an analytics job.
Right. Think about how much time you spend in school to get a degree, but then a lot of people want to work afterwards. So spending maybe an extra 10-20% of your time on developing certain skill sets, it'll make a huge difference in making yourself stand out from the honestly hundreds of applicants that companies get.
Awesome. So with that, let's switch to a couple student questions. So these two, right?
Yes.
So the first question comes from Pauline. Hello, Patrick. Wow, it sounds wow, it sounds like with the position you are at, you must have a lot on your plate and big responsibilities. Keep working hard. A question I would like to ask: what is your typical daily routine at Martin Luther King Jr. Community Hospital look like? And also, do you get to interact with patients in your position?
Good question. It's a big question. Honestly, I think it's probably cliche when people say that I don't have a daily routine. Honestly, my schedule is always packed. There's always a lot of meetings to attend to. There's always a lot of work and collaboration with other departments. And so I think the collaboration is the key part here. I can't develop all these things on my own. I work closely with my boss, Dr. Jorge Reyna, who's our Vice President of Population Health, and he's a key part of developing all of these clinical insights. So, you know, it's something that requires a multidisciplinary team to address. And so my role specifically is to work with other people. I need to work with IT, I need to work with clinicians, and I need to work with all of our analytics resources and developing resources for myself as well. For example, I'm currently project managing the implementation of our data warehouse with our Director of Clinical Informatics. And that is part of developing the infrastructure that's necessary so that we can develop all of these insights and learn about our population some more. So, the daily routine, I roughly categorize it as I'd have a few meetings a day, probably spend about 30% of my time doing analytics, and then a good 10 to 15% of just interacting with departments outside of meetings as well. As for patient interaction, I interact with community members more often than direct patients. Since I work directly in a hospital, inpatients, they have acute conditions that need to be taken care of. And so they're not exactly the people that I'd be interviewing for community health initiatives yet. I'd sometimes with their discharge process, we'll want to talk to them. They are definitely top of mind for several other programs when we're managing readmission rates, making sure after people are discharged from a hospital, they're not coming back with heart failure. But interaction with patients, it's probably more of interaction with community health members and coworkers. However, I know that it would be flexible for my role if I would like to conduct more work with the direct inpatient population. So, I'm assuming by patients you mean inpatients, which are people who are directly hospitalized. But there are a lot of ED patients that I see oftentimes that are technically considered outpatient, even though they're within the hospital because they're not admitted formally.
Thank you. The second question comes from Kathy. Do you use SPSS when managing analytics and strategic operations, or do you use different systemic programs? Also, what tips do you recommend for beginners when navigating statistical programs since various data and features are overwhelming? So I know typically students here, they do have access to SPSS. So I know you mentioned that in the industry, folks don't use it as much. So
Actually, from personal experience, I mean, the one place I know used it was the Orange County Health Agency. I used to intern at the Health Policy and Research Department, I believe. I think that was a formal name of it, but Research and Health Policy, it's public health. And they use SPSS. And that was actually the first statistical package I started using. It's just with the combination of all my recent experiences, I realized that no one else is really using SPSS, at least from who I worked with. It's definitely still relevant because the skills you learn in there are still helpful for learning other programs. So if your professor's teaching it, don't tell them it's useless, please don't. It actually helped shape the framework of how I thought about data. It was my first time working with relational databases and was still very helpful. However, if you're looking to hit those keywords of what those recruiters look for, then SAS, which is SAS, and R are your most common ones. And then SQL is still a huge one if you want to work in any data analytics, because if you can't get a hold of data, you can't do analytics. So let me see if there's...
And then any tips for beginners?
That can go in a lot of directions, I'll be honest. My recommendation is to take a formal course for it first, whether it's at the university or online or on Lynda, and take it with a relational database language first if you want to get into the coding side of things. SQL is much easier to learn than R because R is a little bit more object-oriented. I don't know if that makes sense. But it's just less English-based, maybe. Yeah, SQL is technically structured English query language, I think back when they developed it from IBM ages ago. And so a lot of its functions names make sense. It will say things like select birthday, age, name from a database. Whereas if you want to pull it in Python or R, it probably doesn't look like that. So my recommendation is to start with SQL. That's the most common one. But taking classes takes you a long way because they'll teach you all the housekeeping items, basics, and then you'll be able to teach yourself from there. Maybe give yourself a pet project kind of to work on. There are a lot of public data sources from CMS, which is the Center of Medicare and Medicaid Services. And so you can download their data sets and just practice on there. And you can likely talk about that in an interview, or if anyone would like help shaping that type of project, feel free to reach out to me. I'll share my contact information later with Erin, and you can let me know.
Awesome. Well, those are the two student questions that we'll be covering today. And overall, I just wanted to say thank you so much for coming out and having this interview and talking about all the wonderful things that you can do with data, not just analyzing it and understanding it, but how do you turn this into tangible results that are impacting population health. So thank you so much, Patrick.
Thank you for inviting me.
Bye.